Welcome to the Walrus Talks at Home, Indigenous Health, presented by Johnson & Johnson. I'm Jennifer Hollett. I am the Executive Director of the Walrus, and I'm also your host for this evening. We are thrilled to be joining you online, bringing people together across the country and beyond in conversation. I'd like to start by acknowledging the land that I'm on. I'm in downtown Toronto, Ontario right now, Tekaronto. A land acknowledgement helps us recognize history, thinking about how it informs where we are now and what changes can be made going forward in a commitment to reconciliation. At the Walrus, our offices, and where I am, are located within the bounds of Treaty 13, signed with the Mississaugas of the Credit. This land is also the traditional territory of the Anishinaabe, the Haudenosaunee, and the Wendat peoples. Today, Toronto is home to many diverse First Nations, Métis, and Inuit peoples. We are honored to contribute to a tradition of storytelling, and we welcome you to take a moment to reflect on the land that you're on, wherever you're joining us from tonight, today, or this morning. As part of the ongoing work of reconciliation, if you haven't already done so or have done so recently, we're going to put a link to the 94 calls to action recommended by the Truth and Reconciliation Commission in the comments, and we encourage you to read those. This year, the Walrus turns 20, and we are celebrating 20 years of Canada's conversation, taking a look at who we are now. Find our stories wherever you can, online at thewalrus.ca, in print, on newsstands. This is our current cover story right now, a very important one. Did you know this was a graveyard? First Nations search for their missing children. You can also join events like this one, tune into our podcasts, and connect with us on social media. This work is powered by our donors, our supporters, and our partners. So thank you for being a part of this, and especially to Johnson & Johnson for making this conversation possible. Please join me now in welcoming Jim Pimblett, Director of Government Affairs and Policy at Johnson & Johnson. Hi, Jim.
Hi, Jennifer. Thanks very much for that. Hello, everyone. On behalf of Johnson & Johnson, it's an honor to welcome all of you to this evening's episode of the Walrus Talks, focusing on promoting health equity amongst Indigenous peoples in Canada. Most Canadians take it for granted that everyone should have an equal opportunity to address their best health. But Indigenous people in this country know a different story. There's evidence of long-standing health inequity in Canada, leading to poor health outcomes for many, many Canadians. The stark disparities in health outcomes between Indigenous and non-Indigenous people are simply unacceptable. Indigenous people have been living this reality since before Canada became a nation. Only recently, though, have we seen their truth gain widespread awareness amongst the larger population. Organizations like ours, comparatively speaking, have only just begun our understanding of the historical injustices and systemic barriers that have persisted over time. We are committed to deepening our knowledge and our learning through events like this one, and that's why we're so proud to support it, and working together to identify solutions that ensure equitable access to quality healthcare for everyone. That's why Johnson & Johnson is committed to addressing the calls to action in healthcare put forward by the Truth and Reconciliation Commission. We acknowledge the TRC's recommendations as essential steps in fostering healing and advancing health equity for Indigenous people in Canada. In taking this journey together, we are guided by the principles of respect, humility, understanding, and partnership. Johnson & Johnson is committed to standing alongside Indigenous communities and collectively closing that gap in health outcomes and building a healthier future for us all. Thank you very much.
Thank you, Jim. Colonization has adversely impacted the social determinants of health of Indigenous people, families, and communities. First Nations, Métis, and Inuit people face significant health inequities when compared to non-Indigenous Canadians in nearly all areas of the healthcare system, as well as the social safety net. This is from child welfare, mental health, and addiction services to health governance and accessing culturally appropriate care. The current healthcare system is not working for all Indigenous peoples. Canada needs to pave the way for the improved health and well-being of Indigenous peoples. So what needs to be addressed and where do we start? That's what this conversation is about tonight. Our speakers will be tackling what needs to change for better health outcomes for Indigenous peoples. And tell you a little bit more about the next hour. With the Walrus Talks at Home, each speaker normally has 5 minutes to do their talk live. But tonight, one of our speakers, Victoria Marchand, is unable to join us because she's sick. Health comes first, especially with this topic tonight. So Victoria, we're glad you're taking good care of yourself. That means our speakers will have 7 minutes each. And this will be followed by a moderated Q&A session with our talkers and all of you at home. So feel free to submit your questions at any point in the comment section. And we also encourage you to share this conversation on social media. If there's something you hear, you can quote it, you can tweet it out, you can take a picture to share with us how and where you're tuning in from. Tag us at The Walrus on your favorite social media platform and use our hashtag Walrus Talks. Tonight, we'll be hearing live from Carol Hopkins, the Chief Executive Officer, Thunderbird Partnership Foundation, Melanie MacKinnon, head of Ongomazin Indigenous Institute of Health and Healing at the University of Manitoba, Marcia Anderson, Vice Dean, Indigenous Health, Social Justice, Anti-Racism, Rady Faculty of Health Sciences, also at the University of Manitoba. Thanks again to everyone for joining us. And we're going to start things with Carol Hopkins. Carol, welcome to the stage.
Bueno, bonjour. No jam Indigenous cause gaye main gana dodam. Lena Lenape Quayan Dow, Lenape King and Donjaba. I'm Carol Hopkins, and I'm a member of the Wolf Clan of the Lenape Nation located in southwestern Ontario. And this evening, I'm joining you from the unceded lands and continuously occupied lands of the Salish, Musqueam, and Tsleil-Waututh nations here on the West Coast. This evening, I'd like to share a few points with you. First Nations communities in Canada experience inequitable access to healthcare on a daily basis. And at Thunderbird Partnership Foundation, we believe that the government can do better to ensure that First Nations communities across Canada have universal access to adequate resources that will help them to address substance use and provide treatment for addictions and related harms in the community where people live. The evidence is clear. We know that culturally relevant programming that is grounded in First Nations worldview and evidence delivers tangible results in providing First Nations with the care they need. The government must ensure that First Nations governed treatment centers and community-based services are adequately funded to execute the results-driven approach to addressing mental health and addictions and their services and shortages in First Nations communities. We want to ensure that First Nations people have universal access to the services that they need. From the expertise and experience of First Nations governed treatment centers and communities who struggle to meet the needs of First Nations people who are impacted by drugs and substances and the harmful drug poisoning across this country. And based on that expertise, we've at Thunderbird Partnership Foundation have established 4 recommendations that we've shared with the federal government that we want them to respond to and to implement to address these disparities in access to mental health and addictions programming and resources for rural and remote First Nations communities, but for all Indigenous communities, First Nations, Métis, and Inuit populations. We've said to the government, you have to modernize the current funding formula because without that, we do not have equitable salaries for the addictions workforce in the National Native Alcohol and Drug Abuse Program or the National Youth Solvent Abuse Program. Did you know that First Nations people who work in addictions, that they earn nearly 45% less than their provincially publicly funded counterparts? 45% less than an addictions worker who works off reserve. Now, think about that. What impact does that create? And yet, we've heard that the same workforce will use their own salary to buy food for their clients and transport them, put gas in their vehicles to transport them to access services that may be available someplace else. We've also said we have to develop and ensure measurable and tangible health indicators designed by First Nations people on existing and new federal health transfers to provinces and territories. Canada Health Act says universal access, and services that are available in the province are not always available to First Nations people. And yet we know that amongst First Nations, they've experienced twice the impact of drug poisoning related deaths, as evidenced in drug poisoning related deaths. So 132% increase in the pandemic for First Nations compared to 68% increase in non-First Nations populations in the first year of the COVID-19 pandemic. And we know that determinants of health matter. So the lack of food security for First Nations has been long-standing. It has been further exacerbated by the pandemic as well as homelessness. We know that culturally based indicators for mental wellness demonstrate that culture makes a difference in mental wellness for First Nations. In fact, by being on the land, using land-based resources, it makes a difference in mental health, specifically in the areas of belonging and purpose, having a sense of belonging and understanding that your life has purpose. We've also said to the federal government, we need to have increased transparency, communication, and accountability in funding structures. For First Nations, the funding is based on population size and remoteness, but remoteness is a definition that does not serve First Nations adequately. There needs to be further indicators that and factors that reflect the reality in First Nations communities so that they have the adequate funding to implement the resources and the strategies that they know will work. We've also said that we need to strengthen, coordinate, and integrate services and programming between federal, provincial, and territorial governments. There's a popular belief that if you're First Nations, everything you need for health is located in First Nations communities, and that's just not true. We need to ensure that First Nations people have access to services in accordance with the principles of the Canada Health Act with universal access. But we also have the United Nations Rights of the United Nations Rights of Indigenous People, which has been adopted as legislation in Canada. We need to ensure there's culturally relevant healing practices for First Nations, and that First Nations, who we know are more likely to withdraw from mainstream health and addictions services when they don't feel culturally safe, can ensure that they have access to services that make sense to them, that will deliver the results as measured by indicators defined by First Nations worldview. I want to thank you for joining tonight.
Good evening, everyone. Melanie MacKinnon, the head of Ongamas and Rady Faculty of Health Sciences, University of Manitoba. I am a Cree nurse, originally from Mississippi Cree Nation, and right now I am on Treaty 1 territory and the Métis Nation in St. Laurent, Manitoba. It is an honor to be with you this evening. I wanted to talk a little bit about public policy design and ponder the question on who it serves most. An understanding that public policy is to serve as governments and elected officials. It's there for the protection and the privilege of our providers and our healthcare professionals. It's also there for our policymakers. It's there for our academics and our learners in our institutions. And most importantly, it's there to protect the public safety of the patients and the populations we serve. So it definitely is a must in the area of healthcare and system design. But who does it impact most? And who does it serve most? And so in thinking about that question and learning some lessons from the COVID-19 pandemic and the specific response from Manitoba First Nations Pandemic Response and Coordination Team here in Manitoba, there was many lessons learned. And there was also a lot of heavy lifting. And we wanted to tell you a couple of those stories and those examples in the few minutes that we have together. One of the observations that we had made in our collaborative, or our consortium, as we often called it, was that there was several assumptions and biases being made by policymakers and program designers, and by either level of government, in the case of First Nations specific to Indigenous Services Canada and Manitoba Health in our regional context. And in understanding some of the assumptions and biases, there were, really clear examples around the vaccine clinics and even the urban response, requiring identification to be eligible for a vaccine was a high barrier approach based in bias that most of us have access to personal identification. Or that we can set up a clinic literally, 500 yards from a homeless encampment, and the population and the members of that community would come, which they did not. They did not come because they were really afraid to leave their homes for literally 5 to 10 minutes, for fear of the little belongings that they had would be gone by the time they got back. And so that is embedded in, the privilege, the assumptions, and the biases of the few that have a lot of power. So I want us to think about that, and hopefully we can talk about that later in the Q&A as well. I also want to talk about why that matters. Proper public policy design matters, because if we don't do it right, we can cause significant harm. And in causing harm, we can have poorer health outcomes and significant impacts to the clients and the populations that we're trying to serve. I talked a little bit about the consortium that we designed in our collaborative approach. Collaboration in the constructing collaborative teams and approaches is absolutely critical. And in doing so, it is multidisciplinary. It has to be multi-agency. It absolutely needs to be multi-departmental, if not interdepartmental. We can't be doing the work that we need to do in the Department of Health alone. We need to be working with our partners in education and housing and all of the other areas that have a social determinant to health impact in regard to that specific policy or program. And we absolutely have to work in a multi-jurisdictional approach. And in doing so, and most importantly, it has to be Indigenous-led and First Nation-led. And that was certainly one of the critical success factors for the Manitoba Pandemic Response and Coordination Team here in Manitoba. So we need to take that multi-disciplinary, agency, departmental, and jurisdictional approach, because what we're all trying to do in our efforts to improve equity and respond to the Truth and Reconciliation Action Plan is to solve or to design solutions to improve the health and the outcomes of Indigenous people, which is a multi-generational complex problem that has been most of our work on the panelists today, as well as most of the work that many of you have been doing as well. And so, as I mentioned, it's a multi-generational complex problem, which can be really overwhelming for our allies and our partners and our leaders. But there are areas where we can start, and we can start with the evidence-based approach, the evidence-based data. And really proud that here in Manitoba, we had incredible data and real-time data that enabled us as healthcare leads, Indigenous healthcare leads, to ensure that First Nations in Manitoba were first in line for vaccines, because that's what the ICU data told us that we had to do if we wanted to slow down who we were seeing and who we were treating in our intensive care units. We also have to be cognizant of a low barrier approach. and understanding, the multiple levels of why. Like, why do we do it this way? Why is it that way? What are we trying to achieve with this potential idea or solution? And just keep chunking down the why to understand what the lowest barrier approach we can take to improving equity, like removing the need for identification to get a vaccine. And the third approach would be along the lines of understanding risk mitigation. Think about, your role within the healthcare system and how we are, responsible to our regulatory bodies. We are responsible to our employers, and those employers and the government agencies have a responsibility to us. But think about some of the policy that's designed in your area of work and try to see what the foundational decisions are around risk mitigation, and then ask yourself the question, who is it trying to protect most? Are we making this decision and acting in this way for whose protection? And we can't hide behind the idea of it's the overall, protection of the public. That's important, that's imperative. But that also can be an excuse for some of our policymakers in the way that they've traditionally done business. And I think, again, all of our regions across this country and across the world learned how to do policy and program delivery differently, with some very, very significant decisions we made within our respective regions. And in closing, I just want us to think about, again, in respect to reconciliation, what, from a policy design perspective, do we really need to reconsider or re-engineer so that we can do things better for the shared populations that we serve across this country, coast to coast to coast? Thank you.
Matakiape, Pate Duthunamakiae, Nandue Benesic, Nidishnikas, Chante Washe, Nape, Cheesepae. I'm Marcia Anderson. I'm Korean Anishinaabe. My dad is registered in Pimblett First Nation, and on my grandpa's side, we also have roots in Norway House Cree Nation. And I am joining today from Treaty 1 territory and the homeland of the Red River Métis. As I was prepping for the talk today and pondering the question of what must change to promote greater health equity among Indigenous peoples in Canada, the core sentence or root that I came to was that Indigenous people must be seen as fully human. With the events of today in my head and in my heart, I thought more colloquially, we have to stop being treated like garbage. And I wish that I was just speaking metaphorically. However, I also mean it literally. Unfortunately, today, news was released of a First Nations woman, a 33-year-old mother, a member of Lake St. Martin First Nations, Linda Mary Beardy, who was found in the Brady landfill. And, I want to send my thoughts and care to my sisters on this call who may or may not have heard that news, and encourage you and send my best thought that you'll have some time today to do something that reminds you that you are in fact loved, valuable, and fully worthy. Because while I used to try to power through news like this and distance myself, it is so hard to deny or distance oneself from the unrelenting gender-based anti-Indigenous racism in this country. And so I gave myself time, canceled a meeting, walked over to the hospital gift shop to get some extra steps in and buy a drink, feeling the grief and the anger of that. And as I was walking, I was asking myself, what is the actual difference between the belief system that leads to that and the belief system that leads to the outcome of the quality of healthcare that Joyce Echaquan received. And if you're not familiar with Joyce Echaquan, I would invite you to look up that name later. And what I came to is that I don't see a difference, particularly when we look beyond the individual actors involved in their deaths to the systems that fail to act in response to systemic anti-Indigenous racism or enable and perpetuate anti-Indigenous racism. Now, equitable health outcomes require first and foremost equitable access to the conditions of daily life that are necessary and that promote health and well-being. So when the Truth and Reconciliation Commission of Canada in call to action number 18 asked us to understand the current state of Indigenous health, including the current state of Indigenous health gaps as rooted in government policy, they weren't just talking health policy, but all government policy. Because the nature of systemic racism is that it occurs throughout and across systems. So when we think about, for example, the unacceptably and shockingly high rates of new HIV cases amongst Indigenous women in Manitoba, or the ongoing unacceptable risks of gender-based violence experienced by Indigenous women, we have to understand them in the context of inequitable access to safe and secure housing. In the clustering of Indigenous peoples, particularly women, in the lowest income quintiles in this country, which itself is a result of educational harm done in the Indian residential school system and day schools, the lack of equitable access to education and employment opportunities, and to the past and current legal barriers to building intergenerational wealth. And I think about, for example, the fact that my great-grandpa had to enfranchise in order to get a job off reserve and buy a home for his family. And then I think about the over-policing and under-protection of Indigenous peoples within the criminal justice system. This confluence of system actions leads to marginalization, to structured disadvantage that leads to higher risk of poor health outcomes, whether we're talking about infectious diseases like COVID-19 and HIV, as I mentioned, mental health and substance use harms, as mentioned by Dr. Hopkins, or risks of violence. Now, I would propose that it is insufficient to know what different policy actions to take, such as the implementation of a universal basic income, if we don't change the mindset that led to the past and current policy decisions that have structured and created the gaps that we experience. We, as Indigenous peoples, must be seen, treated, and centered as fully human. When I was in the gift shop today buying a zero sugar Pepsi, there were two young, visibly Indigenous kids. They were probably about 10 or 12 and 4, and they were quietly looking at the toy section in the gift shop. As I paid for my drink, they got asked to leave. Now that gift shop is in a triangle of hallways towards the hospital, a pharmacy across the hall, and the hotel where quite frequently Indigenous people who come to receive care at Health Sciences Center stay. And I would imagine that looking quietly at those toys was one of the few bright moments of joy that those kids had. And they were asked to leave. This is not the message we need to be sending young Indigenous kids if our goal is closing Indigenous health gaps, building a representative Indigenous workforce that will contribute and lead more culturally safe care. The message that we need to be sending is that you belong and we value you in every healthcare space. So I walked away, and as I was walking away, I thought that's actually not the image that I want to leave with today. And so I went back and I bought 2 little Beanie Boos and a couple of chocolate bars. They're similar to my kids' age, had a good sense of what they would like. And I walked across to where they were sitting, waiting in the pharmacy. And I sat down beside the older child and I said, I was in the gift shop and I saw what happened and I wanted to give these to you. and their looks changed from wary to joy. And I thought, what I hope they remember from today is that somebody saw them for who they were and valued and cared for them. Because as the teaching in Dakota goes, Mitakoyasin, we are all related. Those are our relatives. They are our future. Padamia, thank you.
Wow. Thank you for those words. Thanks to our talkers we just heard from, Carol Hopkins, Melanie MacKinnon, and just now, Marcia Anderson. I'd like to check in with the audience as we're going to open up the conversation. Let us know where you're joining us from with the Walrus Talks at home. Where is your audience? Where's our audience? Where is your home? Okay, we have folks registered from Banff, Dartmouth, Fredericton, Calgary. Let's see, Guelph in there, Halifax, London, Montreal. A lot of people tuning in from Ottawa. We also have Vancouver, Toronto, Winnipeg, and Yellowknife. Truly coast to coast to coast. Wow, this is great. As we move into our Q&A session, we have a special guest to lead our conversation. I am happy to welcome and introduce our moderator, Danielle Parody, Western correspondent for Aboriginal Peoples Television Network. Hello, Danielle. Over to you.
Hi, Jen. Thank you so much. Tansi, Sketomawan, Wadakwanak. Hello, everybody. My name is Danielle Parody. I'm a reporter with APTN, as you've heard, and my Cree name that I just introduced myself with there means she carries knowledge. I'm very excited to hear everybody's thoughts tonight. As a reminder, if you have a question for the Q&A portion, please submit it via the Zoom chat, or if you're watching on Facebook Live, please put it in the comments. And I will now welcome back our talkers for our Q&A session. Hello, great. Your introductions were really interesting. I wanted to just start with a really general question. I think I heard a couple of you touch on this already, but what are the major issues that Indigenous communities are facing regarding overall health? I will say, Carol, can you start us off with that?
Overall health to First Nations people means mind, body, spirit, and emotions. And when we think about our physical health, we have to think about where we are. Families, individuals, families, and communities in our environment. So First Nations people are often displaced in Canada from lands rich with resources, current laws that disconnect us from accessing those resources. And so we have limitations placed on First Nations to those very things that are in the lands or in the waters around us, or that grow up from the land, that are now inaccessible by law. They have been removed. We have to have, well, if you look at the news and what happened on the East Coast with First Nations people accessing fish from the waterways that they've always fished from for generations and generations. And now the Canadian public is at odds in a fight with First Nations people over those resources. You think about Ontario and the Ring of Fire and the resources and lands. Yet the school in one of those communities that signed on to the Ring of Fire and the resources that were expected from the land, their school was placed on land that was contaminated. And the children in the school and the teachers in the school started to get sick from that, from the contamination in the land. And while they could ensure that all of this equipment made it to remote and isolated communities in Northern Ontario for the diamond mines, they could not ensure safe, pollution-free school building. No school in that First Nations community. That's physical health. So we live in an environment that has disconnected us from the very things that give us life, yet are accessible to the rest of Canada. emotional health. We do not have counselors and therapists because we've had laws in Canada that said elders and cultural practitioners, that's against the law. And now it's not, but we've been disconnected from the belief in our own selves. And so we're establishing that connection and that belief in our own evidence and our own practices. We know those things work. In our school systems, what have they been teaching all of Canada about First Nations people? We're savages. We're, the opposite party of war. And that's just now starting to change, where our languages and our story of creation, our story of origin, and our worldview is starting to make its way, creeping into the school system, but not far enough. Those are the elements that we have been disconnected from that have created this huge gap, this lack of understanding about what creates and facilitates wellness.
Mm-hmm. Thank you, Carol. Yeah, so often when we start to have these conversations, I think Carol's really highlighted that we have to look at the overall systemic effects before we can even get into some of those other conversations that we've heard, such as drug poisoning today. So another question, and I'll say for whoever wants to answer, Jennifer, Marcia, or Carol, do these health issues that we see with Indigenous, First Nations people, and I include Indigenous just for the audience's sake, because that includes the Inuit and the Métis, such as myself. So you may see different terminology, but that's what we mean when we say Indigenous. Do the health issues that we see vary region by region? For example, do northern or remote communities face different challenges than communities that are closer to urban environments?
I can start off with that answer. And I think, sometimes people assume that that's the case, that it is the geographic remoteness that is the most important determinant of health. And what I think is really important for people to know is that's not true, actually. That systemic racism, as I mentioned, is boundarylessness, not just across systems, but across geographies. So that disconnection that Carol has been referring to occurs also in urban environments. The overcrowded, inadequate housing is very similar between Indigenous peoples in urban environments and rural and remote areas as well. Food insecurity is high. And the impacts of this, for example, when we had the COVID-19 pandemic, were that actually there were many times where cases were higher in urban off-reserve First Nations than they were in communities. And part of that was likely because access to testing and follow-up was greater in the nursing stations, and where First Nations community leaders had their pandemic teams and were actively involved in the response as well. Whereas in urban and off-reserve environments, people had to rely on provincial systems that were not designed to meet their needs. Okay, so I think it's really important that people realize that geography does not equate access to opportunity for good health. Because of the way that colonialism and systemic racism continue to operate in this country.
Thank you so much. Carol or Melanie, is there anything that you'd like to add about that? Just to remind everyone, the question is, do we see the determinants of health or the issues that Indigenous communities face vary by region?
Yeah, I would just concur with Marcia, and we've seen this evidence many years ago with respect to amputation rates, which were actually 18 times higher in First Nations in the South than in remote communities. So again, when I talked about assumptions, there's an assumption that they're in the South and maybe an hour distance to an urban primary care clinic or hospital, and that access to care and treatment is available, and the data tells us otherwise.
I would like to add as well that the assumption is if you live in a city where there's all kinds of services available, then you have equal access, and that's not true. When we think about racism, when we think about the opposite of racism is there's a sense of cultural safety, meaning it's okay to go into the service and be respected as a human being that is First Nations, Inuit, or Métis. And that you don't have to explain what is intergenerational trauma. You don't have to explain what is colonization. You don't have to explain the importance of your own language for expressing your needs that day, that you can access services with someone who has an understanding of all that, and you're not required to educate the service provider before you have access to culturally safe services.
Thank you very much. All right, thank you, everyone. Lots of things to think about there. I want to take us to our next question, and this is one of metrics. So, Melanie, you mentioned data, so I'm going to start with you, but as always, Marcia and Carol, feel free to weigh in. When it comes to stories on First Nations, Indigenous, and Métis health, do we have the metrics that we need to hear and tell the right stories about Indigenous health?
Well, the short answer is no. And then I'm just going to pivot to Dr. Anderson, because she's actually the data guru.
I guess guru is somewhat better than data nerd.
Thank you. Okay, Marcia, go ahead.
Yes. So I would say that having really high quality health data is incredibly important, and it has to respect our multiple identities. So our discrete identities as First Nations, Métis, or Inuit peoples, responsive to gender diversity and other important key elements of our identity. We do not have that equitably across the country or even in Manitoba. And what that creates is invisibility. When we are invisible, such as urban, non-status First Nations people, what happens is policymakers are not using data about us or with us to make good decisions. And so not great decisions get made. But it's not sufficient to have data if that data is not governed appropriately. Indigenous data sovereignty is critical because Indigenous peoples have the relevant expertise that is needed. They have the relationships and connections that are needed to ensure that this data is collected in respectful and culturally safe ways, that is contextualized and analyzed in meaningful ways. And there has to be participation in the decision-making that responds to the data. So yes, we absolutely need better quality and more data, and it has to be tied to the full expression of Indigenous data sovereignty rights.
Thank you very much. All right, I'm going to, Carol, please go ahead.
I was just going to add an example. We often talk about suicide rates. Now, suicide rates are based on an individual number. So we know that for First Nations people, it's 3 times that of the Canadian public, 9 times higher for Inuit populations. But I always ask, when you just think about that number in relation to thinking about an individual, what number is the right number? What number is the right or the magic number that's going to elicit equitable resources to address those factors that lead to suicide? So our data in context means we have to consider, we have to pay attention, we have to focus on the determinants of health. Because when we talk about 3 times higher for First Nations, 9 times higher for Inuit populations, then the general Canadian public thinks about those nations of people and what's wrong with those people, that suicide is happening at those rates, rather than thinking about the lack of schools, the lack of clean water, the lack of housing in communities, the high expense of food in those remote and isolated communities. So the data, we do have some of it that talks about our health or lack of health, but when we use those numbers alone, it takes away an understanding of the determinants of health. that are.
Yeah, thank you very much. Yeah, that's health can include even things like, is there equitable access to of course drinking water. We hear a lot about that, but we don't hear as much about food as we used to, I feel like, and that is a huge issue as well. I'm going to take us to our audience questions. So I think we've begun to touch on this one, but I'm going to throw it out because I think we may have more to say. Is the lack of access for First Nations, lack of healthcare access, that is, for First Nations people similar to other people in rural areas?
No. I'll start off by saying no. And specifically answering related to substance use. So amongst First Nations, just like the rest of Canada, we have a crisis, a public health crisis. We have drug poisoning. Now, the rates of addiction are not increasing, but the rate of toxic drug supply is increasing, and it's causing death. It's causing death everywhere. And in rural communities, because they're rural or because they're remote does not mean they're exempt from the toxic drug supply and the death that occurs from the toxic drug supply. But there are no resources in those communities. Now, again, I said earlier that the funding formula for community-based programming is based on population size, and the one indicator that increases funding is based on remoteness. Meanwhile, it doesn't take into consideration the rate of the population who might be affected by harmful drug supply. It doesn't consider, as I said, the determinants of health and how that might impact on drug use. It doesn't consider those public health perspectives as well as public health measures. So public health does not fund First Nations communities to respond with public health measures. That's a provincial responsibility. But when you go to public health, if you're lucky enough to, have access to those public health resources that are available provincially, they will not always serve First Nations people. So you cannot be assured, if you're First Nations, that you will get access to the off-reserve available resources available to everyone else in that province or in Canada. Will not be made available to First Nations people. Now, why is that? It's a race-based policy. So, if you're talking about access to resources such as harm reduction supplies that might be available in the province, you can't be assured that those are available in the First Nations community that is located outside of the city or more rural or even remote. But we do know that when there are good partnerships in place and First Nations communities are fortunate enough to have access to a clinician who can support the First Nation in addressing the harms of the toxic drug supply, that it's under different funding models. It's under unique partnerships, and that should not be unique. We should not expect First Nations people to travel hundreds of miles to access those resources. And so that's what I was saying earlier by universal access.
Mm-hmm. Thank you very much. Marcia or Melanie, was there anything you wanted to add?
I think I'll just reinforce, because Carol's provided an excellent, very concrete example. But just to reinforce one of the key takeaways we've talked about, which is that the key determinant here is not geography. And then the other point that I want to make around this is sometimes people feel this complexity is overwhelming and paralyzing, but we can and must work through it one step at a time.
Thank you very much. All right, we have a question from Christine, who asks, how can we change individual hospital policies to make our services more welcoming to Indigenous people? They provide some examples here: symbols of welcome, access to traditional medicines, referral pathways to Indigenous-led services, or what are some other ways that they can help to make a welcoming environment?
It's a matter of will. It's a matter of interest. It's really that basic. if people are willing, I mean, people are the ones who can create change. We do not need, I don't know, a magic wand to create that kind of change. That kind of change comes from the will of the people, comes from the interest of the people. So it's not a hard change. It takes leadership, it takes commitment, it takes the courage to recognize the need of human beings within Canada, human beings being First Nations, Inuit, and Métis peoples.
Mm-hmm. Thank you very much.
If I could just build on that, is when we're thinking about leadership, I think it's key that we are building and recognizing the value of Indigenous peoples in leadership positions across the healthcare system, both in dedicated Indigenous clinical organizations and spaces, as well as in the mainstream services that serve a lot of our people. And so representation at leadership positions, sometimes there might need to be amendments to policies and legislations like Regional Health Authorities Act to enshrine Indigenous representation on governing and financially overseeing boards. But across the health workforce, we need to increase Indigenous representation to be leading this work to make the system more culturally safe.
Thank you very much. Okay, we only have a few minutes left, but I hope we can get by a couple more questions. So I do see all your questions coming in. They're great. I feel like we're just scratching the surface here tonight. Melanie, I'm going to start with you on this one. How should healthcare providers and teaching institutes be educated to overcome racism and get a more positive outcome as to how they serve the community? And that question is from SK.
Well, thank you for the question. I think there's multiple ways to answer that question. And so to start with, it's absolutely every academic institution's responsibility. I'm really proud of the work that Dr. Anderson is doing with her team and the advocacy that she and others throughout many, many years, decades, in fact, with some of our very first physicians in the province, Dr. Barry LaValle and Dr. Catherine Cook, who championed anti-racism work before people would even want to hear the word. I think even just 10 years ago, it was still coined the R word, or small R, big R. I don't even know what any of that nonsense means. But we have to do the work. And it has to be done at all levels within the institution, from learners to entry and administrative staff, senior administrators, as well as the faculty. And so Marcia and Carol could probably answer the question better, but it's absolutely imperative. But with that said, we have our responsibility, but we also have a responsibility to ensure that those learners with new ideas, new tools, new technologies, new ways of providing service, new ways of caring for their clients, because that's what we're supposed to do. And as healthcare professionals, we're supposed to care. I know that sounds kind of curt, but sometimes I ask myself that question on a daily basis. But what happens in the clinical environment or the learning environment is also just as critical. And so maybe, Marcia, you can, in your very eloquent way, finish answering that question for me.
Yeah, thanks, Mel. We've been working together so long that I think you've hit a lot of key points already. What I might add to that is that we've worked really hard on establishing national standards. So, for example, having examinable objectives in the Medical Council of Canada. So every physician, before they can get a license starting in 2024, is going to have to be able to answer questions on Indigenous health. We're working locally on OSCE style or demonstrating exams where prospective physicians are going to have to show that they can provide culturally safe care to Indigenous standardized patients and be assessed by Indigenous health workers. And as Mel mentioned, that has to be paralleled by actions in the healthcare system where health learners do most of their learning and where they actually weight the importance of what they see far greater than what we try to teach them in the classroom in the academic institution. So there's a parallel responsibility to have anti-racism policies in the service delivery organizations to those that we have or are developing. Rady Faculty of Health Sciences does have an anti-racism policy, and those policies have to be meaningfully implemented. There has to be accountability. People have to see role modeled for them that anti-racism and cultural safety are core skills for every health worker to have.
Absolutely. Carol, I'll throw to you quickly if you want to have a last word on this one.
I think my colleagues have added quite a bit here. I will just say that the concept of equity, diversity, and inclusion is missing a key factor. And the key factor is that First Nations people have a right to health. And that right is defined in the Constitution of Canada, in our rights under the United Nations Declaration on the Rights of Indigenous People, which is now legislation in Canada. And so we have that added element of legislation which speaks to our rights to health. That's a little bit different when we talk about diversity and inclusion. Just wanted to add that point.
Absolutely. All right. Well, thank you to our esteemed panel. We've talked about some common misperceptions. We've talked about the importance of policy and individual will at the hospital level, and then we've also talked about data and confronting systemic racism. I know there's so much more, but unfortunately, we've reached the end of our Q&A session, and so I would just like to thank our talkers and everyone who joined us today for this really important conversation. And I will now pass it back to Jen.
Thank you, Danielle Parody, our moderator, and our talkers, Carol Hopkins, Melanie MacKinnon, and Marcia Anderson. Lots to reflect on and act on from tonight's talks for our fellow human beings. It's will, as Carol said. I'm going to repeat that. It is will. If you enjoyed tonight's event, we have more coming up this spring. On Wednesday, April 26th, the Walrus will be in Toronto live for the Walrus Talks, a new city with Concordia University. And then on Thursday, May 11th, we'll be in Ottawa for the Walrus Talks. It's happening now, also supported by Concordia University. And these talks are also live streamed. So check in with us at thewalrus.ca/events. That's where you can browse our schedule. You can sign up for any event that you're interested in. Also, someone was asking in chat, where can they get a copy of this video? We post all of our videos online on YouTube and at our website in the Walrus Talks video room. So we'll get that up ASAP. Keep an eye on your inbox. We're going to send you an email as a follow-up. And the best way to stay in touch with us is via email. Just opt in for our newsletter in that message. The Walrus is celebrating 20 years of producing award-winning journalism, podcasts, and events, just like this one. And we can't do this without the support of our incredible community of donors and sponsors. And now is the time for the Walrus to secure our future for another 20 years. So if you enjoyed this free event, consider making a donation at thewalrus.ca. Just click on donate to ensure that we can continue this important work now and for years to come. I have some thank yous before we close it out. A special thank you to Marion Crow, who helped us develop this event. Thanks again to Johnson & Johnson for your partnership. Thank you to our annual sponsors, Air Canada, Inspire, and Shaw. And thanks everyone for tuning in. And I hope you continue this conversation with your friends and family and colleagues. Have a great evening.